everyone, welcome to another MRCP PACES video, Think Like a Medical Registrar series. My name is Vishal Kumar. I am the founder of this channel, Keen Medic, and also keenmedic.com. I'm a doctor based in the UK. Passed my PACES a couple of years ago, and I'm doing videos on topics that you will find beneficial towards your MRCP PACES exam and also to your preparation to becoming a medical registrar. Okay, so today we are talking about Colin's collapse. All right, so let's see what Colin has come in with. In this video, we're going to start off with a scenario where Colin presents. Okay, we'll go through that. Then we'll move on to the bit where you tell me your plan. Okay, you tell me what you're thinking. I'll get you to pause the video at the right time, and then you will come up with your differential, your plan. Okay. And also we'll go through some key considerations, then we'll review the scenario. Finally, we'll move on to the bite-sized bundle for PACES, which I've put together for this scenario for you, because this is going to be very important for your PACES exam specifically. All right, so if you see this symbol, the bell icon, in any part of the video, then do follow the instruction to get the most out of it. Colin is a 46-year-old man who has lost consciousness and has collapsed on the road. Okay, he is out of area and you don't have access to his notes, so you don't know what exactly is going on of late. Okay, however, there is something useful. His wife is with him and she tells you that his past medical history includes type 1 diabetes and hypertension. Alright, so that's quite a significant past medical history. The ambulance crew who attended Colin on scene, they reported he had a consciousness scale of unconscious, unresponsive. Okay, that's what U is. So that's alert, voice, pain, unresponsive. So they found him to be unresponsive when they first arrived. Okay, and with a heart rate of 79, blood pressure of 62/45, very low, as you can see. Respiratory rate of about 20, and he had a SATs of about 98% on air, so quite alright really. Temperature was normal, 36.8. However, his blood sugar was quite low, it was 3.1. And they treated it, they gave him some dextrose, and it improved to 6.2 by the time they got him to A&E. Okay, so in this slide, as you can see, the two main important things are the fact that, three main important things are the fact that he was unresponsive, his blood pressure was very low in the boots, okay, and he was hypoglycemic, and he is known to have type 1 diabetes. So you should be thinking about certain things even now, okay, before we move on. All right, so let's have a look. On arrival to A&E, this is what happens. He remains hypotensive. Blood pressure is 62/44 after 500 mils of IV saline that the ambulance crew gave him. Okay, so nothing has really changed. That's worrying, isn't it? But now he's started to come round, and now on the scale, on the consciousness scale, he's now responding to voice. So that's significant improvement. That's really good. Perhaps it's the glucose that's been corrected, most likely, which is doing the trick here. He's no longer unresponsive. He has come round. He's talking to you if you prompt him, if you talk to him. Okay, so that's good. That's great. Although his blood pressure remains low, he's now talking to you. So that's brilliant. Okay, so let's keep going. What do we find? We get his wife who tells you that he has medications, and these are his medications. He takes Ramipril 5 milligrams once a day. He's on insulin because he's type 1 diabetic. Novomix 30, 20 units twice a day, okay? And as well as Actrapid 10 to 30 units TDS 3 times a day with the meals that he has, okay? So quite significant that he is on insulin, obviously, and he is also an antihypertensive. He doesn't really miss doses, and there's been no issues with compliance, his wife tells you, all right? And there has never been any psych issue either. So, right, what is your differential and what is your further management? At this point, given the information that we have so far, young man with type 1 diabetes, collapsed in the road, out of area, he has been hypotensive, hypoglycemic. What are your thoughts? Have a think. Come back to the video with your list of differentials and your management plan as the medical registrar on call, okay? So, welcome back. So, I think this is a reasonable list of differentials. If I was thinking about it without any further information at all, this is the kind of thing that I would be thinking of. So, if you have any of them, all of them, you are basically along the right lines, okay? So, hypoglycemia secondary to insulin, absolutely. We know that he was hypoglycemic. Maybe he just took a lot of insulin, okay? Or maybe he didn't carb count properly. We don't really know. Um, Sepsis is possible because he was significantly hypotensive. We don't really have much of a history in terms of infective history, things like cough, dysuria, spiking temperatures in the recent past, etc. But we don't really know. Clearly, they've been traveling, so we don't know where else they might have been. Okay, so sepsis is possible. Postural hypotension, absolutely, he is on antihypertensives, right? And he is also diabetic, so you can get autonomic neuropathy because of diabetes. We don't have an HbA1c, so we don't know what his control is like normally. All right, so postural hypotension is absolutely possible here. Intra-abdominal bleeding, that's possible, but we don't have hemoglobin just yet, and we also don't know whether he has had any melena, for example, any abdominal tenderness, for example. We don't know that just yet, but these are all wide differentials that you should be thinking about, okay? And recreational drug use overdose, only because he was so unresponsive, so hypotensive, and he's out of area as well. So we don't, and he's a relatively young man, so we don't really know unless we probe a bit further. Okay, so we don't know. Okay, overdose is possible on the insulin itself. Okay, so overdose can be intentional or unintentional. So unless you probe further with a psych history, you wouldn't know whether he has intentionally overdosed on insulin, for instance. Okay, so a few differentials to be thinking about here. All right, so here's the story though. So 2 hours later, luckily, he has picked up now. His blood pressure is 92/60 after 2 liters of IV fluid. So A&E have managed to IV resuscitate him, and he's stable. And he has now been referred to you. And as the medical reg, you go and see him. This is the history that he gives you. He has had abdominal pains over the last week, he tells you. These are generalized and non-specific. He's never had them before, but these have been ongoing despite taking some painkillers. And he's had some on and off vomiting as well. He is opening his bowels, but this vomiting is continuing. He just feels generally off, lethargic for a long time, for ages, he says, and he's not been quite himself. He says it's possibly been months since he has not been quite himself, okay? And he denies any travels, but he has noticed himself getting a tan in the skin. So he hasn't been on any exotic holidays or beach holidays of late, okay? But he still notices that his skin is getting darker for some odd reason. All right, and he denies any infective symptoms, so that's helpful. No bleeding or melena either. Okay, so that's also helpful. No changes in the insulin or any other medications of late. Again, that's quite important, quite key. And he denies any previous hypos. Apparently, his insulin control, the diabetes control rather, is very good normally, and he is very sensible, very attuned to what's going on. He tests his glucose regularly. He doesn't drive unless his glucose is normal, etc. He doesn't operate heavy machinery. He works in the office. Okay, so he's quite sensible about these kind of things, and he has had no previous drug overdoses or any psych background. So we now have a lot more relevant information to move forward with things. Okay. So let's have a closer look at what's going on then. So you examine him, and this is what you find. You find that he has generalized abdominal tenderness, some tanning of the skin overall, okay, just around the body, especially the palmar creases and the oral mucosa. Just looks darker for some reason, for someone, especially his color, okay. And he is obviously low on energy as he describes. And there are no other obvious findings that you can see. There is nothing else other than these things. Okay, urine dip is unremarkable. It is negative, so that rules out urine infection, and so is the chest X-ray. So that's also clear. Okay, so it doesn't quite look like sepsis picture then. ECG shows normal sinus rhythm. There's nothing obvious there. So this wasn't an arrhythmia that caused him to collapse. That's important. CT head shows no no acute findings, so that's not a bleed or a significant stroke. So that's the important point that you have to look for in the CT head, okay? And also the CT abdomen shows no acute findings. The reason why you did that is to see if there's any intra-abdominal bleeding, or whether this is an acute surgical abdomen, whether it's a perforation because there's a generalized tenderness, okay? But everything, all the investigations that you've done over here in this slide are all normal, unremarkable, okay? However, some things that are quite significant come back. The blood tests are back. Well, of course, the blood tests will come back before the CT is done, obviously. I've given this last on purpose. You'll see why. Sodium is 122. Potassium's 5.9. Okay, so that's off. Okay, both of them are off. Sodium's low, potassium's high. All right, urea is 7.9. Now I'll tell you this is actually raised. Okay, so urea is raised as well. Creatinine is 89, fine, satisfactory, and eGFR is 90. Again, quite satisfactory, quite normal. Everything else is normal, including the thyroid function. Okay, so that's all important, relevant information to think about and to rule out. Okay, so the most relevant information in this slide are the sodium, potassium, and the urea. So remember that low sodium, high potassium, and high urea. Okay, so based on what we know so far, I want you to now think about the diagnosis, the one diagnosis, okay? Young man, type 1 diabetes, on insulin, highest hypo, blood pressure was low, he's out of area, and his sodium's low, potassium's raised. Bit of tanning in the skin as well. Have a think, come back to the video. So, doctor, if you thought this was adrenal insufficiency, you are correct. Well done. So this is what we are talking about today, okay? And basically, we now should go back and think about Colin. So what features did he have? So he actually came in with a collapse, loss of consciousness, okay? Collapse is a term, it's a very generalized term. It is used a lot in the medical field. It doesn't specify whether or not a patient did suffer from syncope or not. That is the key thing. Sometimes collapse is used to describe just pure falls, which are accidental, or sometimes it's used to describe falls with syncope. There needs to be a very clear distinction between the two, okay? So this patient has had loss of consciousness. All right. And he's had a short history of abdominal pain, about a week or so. He's had low glucose, low blood sugars, low blood pressure, low energy levels, okay? He has a background of type 1 diabetes. This is relevant because this is an autoimmune disease. Type 1 diabetes is an autoimmune disease, right? And he actually has a family history of celiac disease, which he didn't tell you about, but you find out later from his medical records because he's out of area, okay? So he has a family history of celiac disease, which is also an autoimmune condition. And he has low sodium and raised potassium, as we know from his blood test, as well as a raised urea. So this is the clinical picture that has brought us to the diagnosis of Addison's, most likely. Of course, we haven't done the diagnostic tests yet, though, have we? So we'll talk about them in a second. So here's a quick overview of Addison's now. So Addison's is essentially primary adrenal insufficiency, also known as Addison's disease or hypoadrenalism, okay? So this basically is a condition where there is destruction of the adrenal cortex, which sits within the adrenal glands, which sits on top of the kidneys on either side, as we all know, resulting in deficiency of glucocorticoid and mineralocorticoid hormones, which would be cortisol and aldosterone, respectively. Okay, results in low cortisol and aldosterone and raised ACTH. All right. And here, finally, we are at the bite-sized bundle for PACES. So pay attention, guys. Well done for getting through the entire presentation so far. This is absolutely key for your exams, okay? So pay attention, make a note, and I hope you learn from it. So the top causes for hypoadrenalism, Addison's, primary adrenal insufficiency, call it whatever, in the UK, in the world are these. So in the UK, it is autoimmune by far. In the world, though, it is quite significantly, it is tuberculosis, okay? So TB can affect any part of the body, pretty much. So secondary to TB, you can get adrenal failure. So that's the top cause globally. Other causes, much less common further down the line, okay, are adrenal hemorrhage or infarction. where something you see in Waterhouse-Friderichsen syndrome, or other causes where there is infiltration within the adrenal glands itself, which means that there is impairment of the cortisol and aldosterone production. Okay, so these would be things like metastases from anywhere in the body, hemochromatosis or sarcoidosis or amyloidosis. So basically anything that can infiltrate into an organ. All right. And other infections like HIV and syphilis. Again, things like TB, HIV, syphilis can affect any part of the body, and this remains true. Okay, so infections like this can also cause adrenal failure. All right, so these are the top causes. The things that you have to remember are autoimmune for the UK and the Western world, okay, and TB globally. These are the important things. All right, let's move on then. So, what are the clinical features? In terms of the clinical features, I've broken down into the chronic and the acute, the crisis period. Okay, so for the chronic side, these are the top things. The ones in bold are the ones that tend to give things away, especially in a PACES scenario. In that scenario, so make sure you watch out for these kind of things. Fatigue, low energy levels, anorexia, low appetite. Hyperpigmentation can be in the oral mucosa, palmar creases, or new scars. Okay, these kind of things. And abdominal pain is generally quite generalized pain. Diarrhea or constipation can happen, and so can arthralgia. Okay, these are chronic pictures of hypoadrenalism, adrenal failure. All right. In the crisis setting, things are much more acute. The patients will have vomiting, they will have dehydration, they'll be hypoglycemic, and they will have postural hypotension. Okay, they may even be confused because of the low cortisol levels. Okay, they may even be confused. That's possible. But the important thing that you have to remember here is that in the crisis situation, anything can cause a crisis. The crisis can be due to an infection, MI, decay, anything. Basically, anything that can stress the body can cause the patient to go into an Addisonian crisis. Okay, even surgery, right? So anything basically that can cause stress can cause a crisis. That's the important thing. Which is why in patients who are already on steroid treatment for primary adrenal insufficiency need to increase their steroid doses if they are unwell. Okay, so that's the reason why. In terms of the investigations, we've covered some of them already. We'll go through some of them again and also talk about the diagnostic ones. All right. So we talked about bloods. So same thing as we have done earlier on. FBC, urinase, and blood sugar are important. In the urine electrolytes, you will find that their sodium is low, potassium's raised, blood sugar will be low. Okay, 9 a.m. cortisol is important if you want to diagnose it and proceed to short synectin test, which is the next thing. If they are in a crisis situation and you want to give them steroids anyway, you can just do a random cortisol. That is definitely an option as well. It is not diagnostic, but it is certainly suggestive, okay? And it can point you in the right direction. Diagnostic, short synectin test, absolutely, okay? Autoantibodies are worth doing in patients where you're suspecting autoimmune causes, and these are the autoantibodies that you would do. Antibody against 21 hydroxylase and also adrenal cortex autoantibody. Okay. These are not necessarily autoantibodies that you would do. You would refer the patient onto the endocrine team, okay? So you are a general medical registrar in the PACES scenario normally, okay? And you wouldn't be doing autoantibodies and stuff like that normally, all right? This is just for your awareness so that you can have that level of discussion with your examiner. In terms of management, again, there is the chronic and the acute side. Let's talk about the acute side first because that is more life-threatening, okay? So in the crisis situation, first and foremost, make sure you correct the electrolytes. If they've got significantly high potassium, that can be life-threatening, okay? So correct the hyperkalemia first. Make sure you give cardioprotective medications like calcium gluconate, calcium chloride, whatever you use in your trust, in your hospital, all right? Make sure that's done. Make sure they're on a cardiac monitor, etc. Okay. Fluid resuscitation is important. Their blood pressure is going to be low, so you need to fluid resuscitate adequately. Make sure they're passing urine. Make sure they're perfused. They have got end organ perfusion and function. Okay. IV steroids are important to get them that boost in the initial phase and get them out of the crisis phase. You give hydrocortisone 100 milligrams IV stat, and you would then put them on regular doses of 50 TDS, etc. If you're not sure, you can always call up your endocrine team, gain advice from them. Okay. The other thing that you have to do is, of course, correct any hypoglycemia that they have got. Very easy to correct, but often missed. You have to give them IV dextrose, get that blood sugar raised into a safe zone. Okay, so this is what you have to do acutely. There may or may not be always a trigger. If there is a trigger, treat the trigger as well. That it may be an infection, bleeding, road traffic accident, MI, anything and everything can trigger it. Okay, so treat that underlying trigger as well. All right, so I hope that makes sense. This is the crisis situation. For the long term situation, the first thing you have to do is, of course, refer to the endocrine team if they are not already known. Even if they're known to them, you still should refer to the endocrine team, because if they have had a crisis, their management may need adjusting. Okay. Steroid card and education are important. This can be organized by the endocrine team as well, and they will follow the patient up. Normally, what happens is they end up on hydrocortisone. There is a higher requirement early on in the day. So, usually, for example, a regimen of 20 milligrams, 10 milligrams, and 10 milligrams. Okay, so that's usually, for example, a regime that a patient might be on. There's a typo error here, so that should be 20, 10, and 10. Sorry about that. And also, of course, fluorocortisone, because they would be devoid in aldosterone, so fluorocortisone would replace that. Okay, not everyone necessarily ends up on it, but quite possibly. Okay, so that's what you should be knowing. Make sure you take a screenshot, make notes, whatever. This is the kind of thing you should be knowing for your PACES exam, things like you should be looking out for, all right? So I hope that made sense, guys. If you want to learn more, make sure you check out my book, available in Kindle and also paperback forms. Link is down below, and also my course, also linked down below. All right, I will see you in the next video.